Okay. So the last time, I think we ended here, okay, organ donation. And one thing that we should be aware of is that sometimes when patients are about to die, they want to donate their organ, okay, or tissue. And then there are laws that bind that, okay. So first of all, if a client wants to donate his or her organ, the client must be what? Competent. All right. And should be over the age of 18 years. Okay. So they can either decide to decline or approve organ donation. Okay. So with a deceased client, a family member cannot consent. If the person did not have any okay, so please, can you mute up? Please, let's mute up. Okay. Okay. So, a minute. Okay. So with organ, please let's try to meet up. Okay. If the disease client.
Okay. Want to dining why? Want to get in.
Hello. Please let's try to meet up. Okay. Okay. So if the disease client did not have any advance directive, it means that a family member can consent. Okay. And with a request is done by the what? The healthcare provider. Okay. Or a specially trained nurse can do the request. All right. But it should be included in the advance directives, as I said, or the living will. It should be in the advance directive. And if it's not in it, it means that a family member can consent to organ donation, okay? And donation does not delay funeral arrangement as well, okay? So it shouldn't delay funeral arrangement, all right? All right, so that is about organ donation. Okay, so it should be in the advance directives, okay, or the living will. If the client has stated that I don't want to donate my organ, after passing out, no one can override that. Okay, if the client says that I want my organ to be donated, that one, since it is in the advance directive, we can't override whatever the client has said, not even the proxy. Okay, so please take note of that. All right, now to informed consent. And this, we normally do it prior to what? Non-emergency procedures. Okay, so if the case is not urgent, then we have to let the client sign an informed consent. Okay, and the healthcare provider is responsible for obtaining the consent form. Okay, it is the healthcare provider, it is his responsibility to obtain the consent form. All right. So we say that if it's not urgent, then you have to sign a consent form. But there are exceptions, okay, in cases of what? Emergency or life-saving procedure. Okay, so if, for example, if the client came in with a road traffic accident and no one is there, okay, in such emergency situations, we have to what? Do without having a consent form. All right, so that is what we should take note of. And then we also need consent in some situations. Okay, for example, when you are admitting a patient, you need to what? Request for consent form. And immunization, when you are giving immunization or even blood transfusion, okay, we need consent form. All right, so we have to take note that's with blood transfusion or when we want to immunize, the patient must consent to that. All right, so please take note of that. And apart from that, when you're going to surgery, which is most common way of what? Consenting to the procedure. So the patient must consent to the procedure before we can operate on the patient. All right. And whenever there's research, ongoing research, they want to use the patient, the patient has to consent. Okay. And for genetic testing, that one too, the patient must consent to that. Okay. Or when you want to use restraint, whenever you are restraining a patient, we can't just go about and restrain the patient. We need to have a consent form. Okay. And autopsy or photographing a client. When you want to do autopsy, when you want to photograph a client, we need a consent form. We need a consent form. All right. So these are some of the situations whereby we may need a consent form. All right. Okay. And we have component of consent form. All right. With consent form, client must be what? Must take the actual decision. Yes, please. Mr. Vivian.
Okay, please. I want to find out, you said if you want to restrain, you need a consent. Do you mean you need a consent from the healthcare provider, like prescription, or the patient have to consent to it before you restrain? Please, I want clarification. Thank you.
All right. Yes, class, who can help us? Is it the healthcare provider who should consent or the patient himself? Yes, please. Yes. Yes, Sister Roberta, can you help?
Yeah, it's the healthcare provider.
The healthcare provider should consent. Okay. Mr. Karim. Thank you, Sister Roberta. Mr. Karim, what do you think?
Yes, boss. So, yeah, like what the sister just said. So, you have to obtain a restraint warrant from the healthcare provider.
Okay. Who else? Who wanted to
Yeah,
talk?
what I also know is the healthcare provider, you should get an order from the healthcare provider that is within the first 24 hours. Even if it's in an emergency and you restrict the patient, you have to obtain an order from the healthcare provider within the first 24 hours. And also seek a consent from the relatives, the patient's relatives, or the patient itself. Yeah.
Okay, thank you so much, Sister Rita. Any other? Okay. All right. So over here, the patient that you are restraining should consent. Okay, the patient should sign a consent form. Okay, or if the patient himself is incapacitated, okay, or then the family members can consent to that. Okay, the proxy can consent to that. Okay, but as others have also contributed, we need to get an order from the healthcare provider. All right. Yeah. So someone is saying that, Sister Abigail is saying that, I think in an emergency cases, you can restrain without healthcare provider consent, but after the 24 hours, you need to inform the healthcare provider. That's it. Okay. So as we said, there are emergency situations, I said in the beginning, that you have to what? Go ahead and do whatever you want to do. But afterwards, you need to get a consent form. So as he's suggesting, that is exactly what we are supposed to do. We should, if the patient needs to be restrained, okay, physically, then we have to what? Restrain. Then after restrain, we need to get an order from the healthcare provider. Yes, Sister Ifya.
Yes, good evening, team.
Good evening, sister.
Please, I need a little clarity.
Okay.
I want to know whether the physician is the same as the healthcare provider or the healthcare provider is different from the physician, please. Thank you.
All right. Thank you so much for your question. Yeah, we mean the same, okay? The same person, the one taking care of the patient. All right, that's what we are referring by different names. I hope you're okay. Yeah, this is a patient.
Yes, please.
Please, I also need clarification. When you restrain without doctor's order, do you have to wait after 24 hours before you seek for his order or during the first 24 hours? Thank you.
All right, thank you. Yes, who can help us?
I'm sorry, please, I didn't raise my hand, but it's within the first 24 hours. So immediately you restrain without an order. Within the first 24 hours, you should make sure that you have an order from the healthcare provider. Thank you.
Okay. Thank you, sister. Any other? Yes. Any other? Okay. So that's that. Okay. So you need to get an order from the healthcare provider within the first 24 hours after restraining. Okay. You need to get an order from him before what, and wait for him to say whatever you want to say. If there's the need to keep on restraining, or if there's the need to use other method of restraint. Okay, so that is that. All right, so I hope you can continue. All right, so we are looking at component of client's informed consent. Okay, before a client can consent to a treatment, okay, we look for the client capacity. The client capacity. That is the client having the decision-making skills, and the competency of the client. Okay, the client must be competent enough to sign the informed consent. Okay, and it shouldn't be forced. It should be voluntary. Okay, no one should force someone to sign a consent form. And the patient can also withdraw even after signing the consent form. So even if the patient is on the table and the patient wants to withdraw, you can go ahead and do that. Okay, so please take note that so please, if you have any question, okay, you can go ahead. Okay. So what I want to let you know is that the patient can withdraw at any point in time. Okay, so don't think that after signing, the patient has already signed, so he can't change his mind. No, he can do so at any point in time. All right. Then we need to make sure that the client is competent, as I said. So if the client is having delirium, okay, or patient is on any of these medications that can alter the mind, okay, like opioids. Patient has taken opioids, okay, like what? Morphine. Patient has taken alcohol, or legally patient is deemed incompetent. Then, in these cases, client is what? Incompetent. Client can't sign a consent form. So if the client has taken alcohol, he can't sign, okay, or patient is delirious, or he has taken opioids, okay, or legally the patient has deemed incompetent. That means the client can't sign a consent form. All right. Okay. So informed consent, there are special considerations that we have to take note of. Okay. So we always have to, with the special consideration is that if the client is incompetent, then we have to what? Contact the next of kin. Okay. Or the legal guardian, or if the patient is having medical power of attorney, then you have to contact any of these. All right. So if the client has taken, let's say, any mind-altering medications and deemed incompetent, then we can contact the next of kin, can come in and sign a consent form, or the legal guardian, or if the patient has a medical power of attorney, he can come in and sign the consent form. Okay. But if the client is a minor, then the guardian or the parent can sign. Okay. But there are special considerations too with regards to minors. Okay. I want to ask, what are some of the considerations or situations that a minor, someone below, let's say below 18, can sign a consent form apart from the client being married?
If they are pregnant.
If the client is pregnant, he can sign
Yes.
a consent form, though he's a minor.
Yes.
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 And if the
client
child is in the military?
If the client is what?
In the military.
Military. Okay. You mean that the
Yes.
client can sign a consent form even though he's a minor? Yes. What other situations?
If the minor proves or gives the impression that they understand what you are explaining to them.
The client can do what?
Okay, a minor who appears to understand what you're doing, what you want the consent for, who understands the procedure.
So assuming you are,
or rather who has the capacity.
This is Atina, you want to talk?
Yes.
I think what she's trying to say is if the minor is emancipated, so for instance, at the age of 15, the minor doesn't live with any guardian. The minor fends for him or herself, and at the moment has nobody who is actually a guardian to him or her, and understands the repercussions of the procedure that is going to be done, that person can sign for him or herself. So the underlying thing is the minor has to be emancipated
Yes.
and has records to show. So
Okay.
records like maybe where the person works, they pay him or her, the person lives alone, but is able to manage with rent and then other utility payments.
Okay.
Thank you.
This is a patient. Can you which one? What are you
Please, I
trying
want to find out with the first point.
Wait, what?
Special consideration for incompetent clients. You said contact next of kin, legal guardian, and I want to know the one that you should contact first in case of it.
Okay. So if the client has a medical power of attorney, then we can't ignore that. Okay. So we have to contact, so far as the client is having a medical power of attorney, then we have to contact that person first. All right.
Thank you.
All right. So, okay. So, we've known that if the client the client is what emancipated minor, then he can or they can go ahead and sign the consent form. Okay. What about if the client is receiving treatment for maybe substance abuse? He's a minor and receiving treatment for substance abuse. Can you go ahead and sign? Yes.
Yes, me, I don't know about that.
Okay. Okay.
Hello?
Yes, please. Sister Tini.
I don't think the minor can go ahead and sign because he or she will be under the influence of a drug. And we know that if somebody is under the influence of drug, they can't give like competent consent. So I think it will be a no.
Okay.
Okay, not true because they are not of sound mind. They say those who are not of sound mind, they cannot sign their own.
So they
But
can't
yeah,
sign.
if you are, yes, please. That's what I'm thinking.
Any other? Okay, in emergency situation that the minor is receiving treatment related to substance abuse. Okay, I'll come to that. What about if the client is receiving treatment related to sexually transmitted infections, like maybe HIV? Yes.
They can. They can.
So that's the one they can.
They can.
They
All right.
can.
Even
Because they
for
are
family, they can. Family planning too,
Family
they can.
planning, yes, even family planning, they can.
Okay. Okay, family planning, right? They can. Okay.
Yeah.
All right. So, if the client in emergency situations, yeah, Sister Kese.
Yeah, I think with the HIV patient you are talking about, I think it depends on the condition of the patient. Usually with this toxoplasmosis, usually because the HIV virus could get into their brain and then alter their thinking and all that, especially patients with toxoplasmosis. I don't think they can sign consent form when they are in that state. So it will really depend on the stage of the HIV virus in the patient.
Okay.
That's what I have to say.
All right. Thank you. So as we made known to you, if the client is in his or her delirious states, okay, so if the condition, you read the condition and the client is having delirium, okay, or confusion, acute confusion states, okay, so it means that they can't sign a consent form, though it's a minor, okay, and or even if it's not a minor and is having these conditions, so far as there is situations that can't warrant the client to send a consent form, you have to agree on that, okay, and withhold the client from signing the consent form. In that situation, if he's having a legal guardian or medical power of attorney, they cannot come in and sign. All right. Are you okay, please? Okay. So, in an emergency situation, yes, Sister Vivian.
Sir, so please, with an emancipated minor like our sister was explaining, if that person is emancipated, okay, but is under the duress of drug, and that person cannot sign, what happens before a procedure can be done? Thank you.
The person is under an influence of drug, is that it? And he's what?
Yes. And the person is emancipated as well.
Okay, okay.
He or she takes care of himself and all that.
Okay.
What happens? And that person definitely is not having any next of kin, no guardian, nothing. So what happens? Thank you.
Okay. Yes, who is willing to help us? The client is emancipated, is under influence of drug, and we can't let the client sign. What do we do? Yes.
Can I try?
Yes, please, you can.
Okay. If it's an emergency in that particular situation where the client is unconscious, let's put it that way. A nurse can do that, but it doesn't have to be a nurse that is looking after the client. I read that from somewhere. I don't know. I stand to be corrected.
That's in emergency situations, right?
Yes.
Okay. So
because the medical team can do that in an emergency when there is no other person who can do it, or they really have to do it at that time. They cannot wait for somebody to come in. The medical team can do that. So either the nurse or the doctor. Now, I read from somewhere that not a nurse who is directly concerned with the patient's care.
Okay.
I stand to be corrected.
All right. Thank you. Any other idea? Okay. So, yes, so in an emergency situations where the client, though is emancipated, is under the influence of drug, no matter what the type of client, okay, whether the client is deemed competent, whether the client is emancipated minor, okay, and so far as the client is under the influence of drug, the client is having delusion, the client is confused, okay, we can't allow the client to sign a consent form. So if it's urgent or the situation is needs an emergency treatment, then please, someone is signing on my computer. So if the client is deemed incompetent in these situations, then the healthcare provider can go ahead and use his or her discretion to do the surgery or give the treatment. All right. Okay. So what we have to know is that if the client in emergency situation, I initially asked a question. All right, if the client is receiving treatment related to substance abuse, and the client is a minor, okay, the client can sign so far as he is not under the influence of what? The drug, or at that time, the client is competent. Okay. If at that time the client is competent and want to receive treatment for substance abuse, the client can go ahead and sign. Are you okay? So please take note of that. Okay. So what are our nursing intervention if the client is going for an emergency treatment, or even client is signing a consent form? What are we supposed to do as nurses? First of all, we can witness, okay, and verify that the client is voluntarily signing the consent form. Okay, so we can verify, okay, the signature of the client. Okay, we can witness. So we should be there to witness and verify that the client has signed the consent form. Okay, and if the healthcare provider has provided information to the patient, okay, has already explained the condition to the patient, and the patient needs clarification, and then the healthcare provider is not there, if the nurse is there, the nurse can clarify those facts. Okay, the nurse can clarify those facts. That has been what? Provided by the healthcare provider. Okay, and we have to also make sure that the client is competent enough to sign a consent form. The client understands the procedure. Please, Rahul, for whoever, please, you are disturbing us, please. Wafayatu, please. So you as a nurse, you have to ensure that the client is competent and understands the procedure, and then understand the care plan. Okay, if the client after the surgery, the client would need wound care or diet or post-surgery care, you have to make sure that the client understands all these. Okay, and the RN, we are not responsible to give the detailed explanation of the procedure. It's not your duty. That the client is going for a surgery and you are there to give detailed explanation of whatever thing is going on. You are giving like what the client is supposed to expect, and the side effects of the procedure, whatever. You are not supposed to do that. So it's not our responsibility to give detailed explanation of the procedure. All right. So that is that with consent form. Any question before we move on to? Okay. Then client also, they have rights. The clients have rights. Okay. And the first right that we are talking about is what? Right to privacy. Okay. So when we are caring for clients, and even in public places, okay, whenever you are caring for the client, and the client is in your room, okay, I mean in the hospital, okay, we have to close the door. Okay, if you do so, we are ensuring what? The client's privacy. We have to close the door. Or if you can't close the door, we cannot draw the curtain. Okay, you can draw the curtains. Okay, to ensure that you have provided privacy to the patient. All right. And if you want to give client information to any other person, make sure that the one that is receiving the information is directly related or directly caring for the patient. Assuming a nurse from different units comes to you and requests for client details, okay, our client's information from you, you are not supposed to give those informations, even if it's a doctor. Okay, you are not supposed to give those information out. Okay, because those people requesting for the information are not directly caring for caring for the patients. Okay, and clients have right to get copies of their own medical records. They have that right to get copies. So if they request that they want to get copies of their medical records, they have that right to get those copies. All right. Or if they've already provided inaccurate information, okay, they can change those information at any time, any point in time. Are you getting it? Okay. So if you are sending information to a patient, want to send information via email, okay, or on phone, okay, you have to what? Let the client tell you what he or she prefers. Okay, if the client is choosing maybe email, you have to send the information via email or phone. Okay, you have to send the information through that. And if you want to leave a message on that phone number that the client has provided, you have to ask the client whether you can leave a message on the phone. Because sometimes when you the client might not be the sole person using the phone. Okay, so you have to ask the client whether you can leave a message on the phone. By so doing, you are protecting the client's privacy. Okay, and if the next point says that signed consent is required to share the personal health information to different, or when the client wants to change a doctor. So if the client wants to change a doctor, okay, or if the client wants to share his or her information to a different person, then the client needs to sign a consent form. Okay, except in emergency cases where we can share those information to, let's say, the physician. Okay, so it means that the client needs emergency care. We have no other option than to share those information. Okay, or if there's abuse of children, if we see that there's abuse of children, then we can share client information. Client has come to you with a child, and you can see that the child is being abused. Okay, or you can see like strips of cane on the child's back. Okay, you can share the client's information. Okay, you can report. All right, so in those cases, we cannot share the client information, all right, without consenting to that, all right? Or patient is vulnerable adults. Okay, you see that the client has come to you with his or her husband. The client has come to you with, let's say, a client is a female, he comes with the husband, okay? And you can see that the client is not safe. Per your assessment, you could see that the client is vulnerable. Okay, then you can go ahead and share the client's information. All right. So clients also, they have another right of informed consent. Okay, so they have the right to do that. Okay, so when they can either choose to sign a consent to a particular treatment or not. Okay, so if you've given appropriate all the needed information to the client, and the client says that I don't want, then you have no right to what? To force the patient. The client's right to do that. Okay, the client's right to do that. Okay, so it should be always voluntary. Okay, so far as the client is competent. All right, so the client also can refuse treatment or anything. The client's right. He can refuse it. Okay, even he can refuse life-sustaining treatment. I don't want you to put ventilator on me. The client can choose that. Okay, so we always have to what? Follow the client wishes that are found in the advanced directives. Or if the client is having do not resuscitate orders. Okay, if so far as it has been stated, we have to follow the client's wishes. All right, and if the client want to leave against medical advice, he has that right. Okay, so far as it's competent and not a danger to self or others. Okay, client can do a harm or can harm what? Himself or others. In that situation, we cannot let the client go. So far as the client can harm himself, so far as the client can harm others, we can't let the client go. But if there is no such danger, then we can let the client leave against medical advice. So the only situations that the client can, we can restrain the patient or we can't allow the patient to go out if the client is what? Is in danger. He can cause harm to what? Himself or others. All right. So we can't let the client go. And then if the client want to leave and you detain a client, it can resort to what we call it false imprisonment. You are imprisoning the client falsely. Okay, that's false imprisonment. The client want to leave, but you want to detain the client. That's false imprisonment. All right. So the client also has the right to his personal belongings, okay, to secure their valuables and their document as well. All right. So he has the right to have what? Freedom from what? Physical restraint. The client tells you, I don't want you to restrain me. Okay, it's the client's right to do that. Okay, so we only use physical restraint as the last resort. Okay, so we can do one-on-one observation. We can use distraction or reorient the client if the client is confused. Okay. Yes, Mami Dufie.
So if the client wants to leave against medical advice, what should you do? You just let the patient go, or he or she has to sign a consent for that? Thank you.
All right. Is someone answering? Yes. Do you have to let the client sign a consent form?
No.
Why
No,
not?
but some mostly they let them go and type their own letter and bring it that they are living against their medical.
Okay. It's a button. It's a button.
No, they don't have to sign. They don't have to sign a consent form, but you have to document your notice that this is what the client opts for, and you have to respect client's autonomy too.
Okay. All right. So if the client,
Can I also talk?
yes, please.
All right. So if a client will request discharge against medical advice, the patient will sign a consent form as evidence, but the patient will get all the medication that he was supposed to get when he was supposed to be discharged normally. All the discharge instructions, everything will be given to the patient. And if the patient leaves the hospital and then comes back in an hour, he is also liable to the assessment. So everything that the patient is supposed to do will be done for the patient as discharge process, but it's still against medical advice.
Okay. Sister Ma, I think one Sister Ma rose her hand. Sister Ma,
Yes, it's just what the gentleman just said. That's why I lowered my hand again. But I think the little I can add is that I think maybe you have to provide information on that decision, especially with the consequence of that action, the current situation, and help the patient to really understand what situation is there and then what the results will be. And then if later the patient still thinks he wants to go against medical advice, then you sign the consent and all that.
okay. Sister Catherine. Sister Catherine, do you want to talk? Okay. Sister Annette.
Hello, good evening, sir.
Good evening.
Please, mine is a question. Please, so let's say in situation whereby patient is not mentally sound. So during admission, is the family members who brought patient to admission, and then along the line, patient is getting a little better, so he or she requests to go home. In that situation too, can you allow patient to go?
That the client is what?
Thank you.
Please come again. The client
Mentally sound.
sound.
The person is not, the person is not sound.
It's
Let's
not
say
sound.
the person is a psychiatric patient.
Okay.
Yes.
Okay.
Let's say the person is a psychiatric patient or something. So it was the relatives who brought the patient on admission.
Okay.
But along the line, patient is becoming aware of his or her environment, and then he or she requests to go home. In that case too, does the patient have that right to go home?
Yes. So as we said, so far as the client is safe, not to cause harm to himself or others, the client has that right. Why not? Okay. So that is the client's right. Okay, the client's right. So don't say that the client was. What about the current state of the clients? Is still is the client still confused, or is still in that state, previous states, or the early state that he came with? So far as he's sound, okay, he's oriented, he knows what he wants, then the client can leave against medical advice. Okay. But if the client wants to leave against medical advice, we should have an evidence to show. We can't let the client go. Just it's the client's right. Yes, that is his right, but he wants to go. What shows that the client is living against medical advice? You have to get an evidence. Okay, so you can either let the client sign a consent form, or sometimes they have to provide something that backs that he wants to live against medical advice. Because you should have evidence. You should have evidence to prove that. Because what about if the client comes later, or even if he goes and something happens to him or her, and the relatives comes and they can sue you for that. If there's no backing, you cannot prove that the client left against medical advice. So always you should have evidence to prove that. Hierarchy, please.
What if the client refuses to sign?
The client refuses to sign. If the client refuses to sign, of course, we have to let the case manager or our supervisor comes in, okay? Because we should have evidence. If you want to leave, why don't you want to sign? Okay, so per assessment, it could be that the client is confused. Okay, so we have to also assess the clients that he want to leave. The client is not leaving to cause harm to himself or others. You have to assess the client, okay, before he leaves, okay, to ascertain or to make sure that the client is safe. But why don't you want to sign if really you want to leave? Okay. All right. Can we move on? Okay. So, all right. So we said if the restraint is needed, that's the point, this point 3, okay? If you want to restrain the patient, means that the healthcare provider must include the purpose. So why do you want to restrain the patient? As a healthcare provider, you have to what? State the purpose of restraint and the time frame. Okay, I want to restrain this patient because he's causing harm to others. Okay, the purpose must be stated. Then, when do you want to restrain the patient? Do you want to restrain the patient for 30 minutes or 1 hour? You have to state the time. Okay, and a type of restraint. Is it physical restraint or chemical restraint? Do you want to use drugs or you want to physically restrain the patient? Okay, so the type of restraint must be included, the purpose and the time frame must be included in the order, all right? And always, every 2 hours, we have to what? Assess the clients. We have to assess the clients. Wherever you, especially if the client is having physical restraint, okay, we have to assess the client. Is the restraint restricting or constricting blood vessel? Okay, we have to assess the client, or the clients want to go to visit the washroom. Okay, so every 2 hours, we have to assess all these things. All right. Apart from that, what other things can we do when we are restraining a patient? Apart from this assessment, what other things can we do? Yes. When restraint is applied. Yes, who wants to help us? Are we there? Yes, please. Yes, please go ahead. Miss Ama.
Okay, mine is not directly with when the patient is restrained, but I know that before the restraint order is given, there should be a documentation of other non-restraining approaches that have been used and have proven ineffective before you decide to go for the restraint.
All right. Thank you so much. All right. Yes. What other assessment will you have to make when the patient is on restraint? Yes, please. Go ahead and speak. Sister Linda.
Yeah, but Frank, please, I know that if a patient is, for example, is wrist restrained, you have to monitor the patient's both distal and proximal extremities to check if there's proper circulation to the hand. You have to monitor if there's any edema or anything that can impede circulation to the arm. Yeah.
All right. All right. All right. Thank you so much. Okay. So we must take note of it. All right. Okay. So, restraints can be considered what false imprisonment. It's like detaining a patient after patient has requested for it, to leave against medical advice. Okay. So when you falsely restrain the patient, it can be deemed as what? False imprisonment if the patient didn't consent to that. Okay. Or you didn't have any proper justification. You couldn't justify the reason why you restrained the patient. It can be considered as false imprisonment. All right. Okay. What are we supposed to do as nurses for clients' rights? We have to always protect and advocate for the patient. You protect the client's right. And we have to also adhere to standard of care. Okay. Or if Nursing Practice Act, we have to adhere to that. Or if the organization has a practice act, that we have to adhere to that. Or if they have a policy, we have to uphold to that. Okay. And we have to also know that we have a legal obligation to our client. Okay. But there are situations, okay, there are situations where we can violate the client's right. Okay. For example, when you take clients' photos, okay, without their consent, it's a violation. You've violated the client's privacy. Why do we want to take a photograph of a patient without informing him or her? Okay, you can't do that. Okay. Or if you disclose client information publicly, okay, if you disclose client information publicly, you have violated client's right. Okay. Or if you leave a confused client, okay, or if the client is agitated, all right. If you leave the client, if the client is confused or agitated, you leave him to sit in the nursing unit. All right. So we don't leave the client if the client is confused to sit at the nursing unit. Do you get it? So always take note. And if you don't close the door or draw the curtain, as we also said, you have violated client's privacy. Okay. Or if you are using the client's name, okay, or anything that belongs to the patient, like client photograph or picture, okay, if you are using that for the purpose of the hospitals or the facilities advantage, for their advantage, if you are doing that, you've violated the client's privacy. Okay. Or if the client's own affair, you intrude the client's own affairs, you violated the client privacy. You don't do that. Okay. So these are some of the things that we can do to violate the client privacy. Okay. Or sometimes if there's something which is so embarrassing, and you do publication of those embarrassing facts, you violated the client's privacy. Okay, so please take note of this. Okay. Any questions so far? What about, let me ask you, what about if you are interviewing a client? Okay, you are with a client in a room. Okay. And then, though you've drawn the curtain, but your conversation is being overheard by other clients. Have you violated the client's privacy or you've provided privacy?
I think you have provided privacy.
Okay. Any other, please?
Yes, please.
You provided privacy.
Please, you have provided. Yes, please.
Okay. So if the client, if the context is someone talking
I
to,
don't think you provided privacy because
okay,
someone else is hearing what you are saying. So there's no privacy in this.
okay, all right. So
Oh, please.
mm-hmm.
Sorry. At that instant, there is no door to close. There is no window to close. The only thing is there for you to
Curtain.
use as providing privacy is the curtains. So once you draw the curtains, you've provided privacy. If another person hears a conversation, it's not your fault because you don't know whether there is another person behind the curtains, but you provided the privacy with the curtains. So it will not be your fault for if another person hears your conversation.
Okay.
Even though you can do well to put down your volume, especially if you're sure that there are other clients in the behind the curtains.
Okay.
Thank you.
All right. So please, so far as your voice is being heard, you are violating the client privacy. That's why you have to talk in a low tone. Okay. So we assume that you've drawn the curtain, but you are speaking on top of your voice. You're not providing privacy. Okay, you are violating the client's privacy. All right, although you've drawn the curtain, so far as your voice is being heard, you're not providing privacy. So always, if you want to provide, after drawing the curtain, you have to lower your voice. Okay, to ensure that your voice is not being heard. So if you say, it's not my fault, I've provided privacy, but can you speak on top of your voice to let the client's information to be known by others? No. The client information should be only be known by the client themselves or those providing direct care to the patient. Sister Susanna.
So in the case of when you are interviewing a patient who is having hearing impairment, and you know with those people, you can't talk under tone. Sometimes you need to shout for them to hear. In this case, you've drawn your curtains, but the other patients next door got to hear of what you are saying. Have you violated privacy? Because one, with your patients, you have to shout for your patient to hear.
Okay.
You've provided privacy, but the patients next door heard of the information.
Okay.
Is it violation?
All right. Any answer? Yeah, Mr. Karim. Mr. Karim, please talk.
Yes, Boss Frank.
Yes, please.
Yes, please. So, what I know is that even if the patient has a hearing impairment, you don't need to shout.
Yes.
You still have to speak at your normal tone.
Yes.
But you have to face the patient squarely.
Exactly.
Yes.
Exactly. So we don't shout to clients who have hearing impairment. We don't shout. As Mr. Karim said, we have to do same.
Okay. Thank you.
All right. Okay. Can we move on? Okay. So what about Sister Vivian?
Yes, sir. About the privacy thing, sometimes in these wards, they are better close by and they just have the curtains in between them, okay?
Mhm.
And then you are talking to the other patient. And for some reason, the other patient next behind the other curtain gets to hear. I mean, what more can the nurse do about it? Because you've drawn the curtain, but it so happens that there's a patient next to the curtain. So with that, what happens?
Yeah. This is Abigail. I think this Abigail has answered on the chat box. This is Abigail. Can you speak up? Debbie, are you there? Okay.
I'm with my kid. He will be making noise. That is
Okay,
why.
okay, no problem. So far as I'm Sakarim.
Yes, please, boss. I just want to contribute a little to what
Alright.
the sister asked. So, if you look at our setting here in Ghana, yes, most of our wards, you realize that sometimes we have a lot of patients in one ward or one room, and we use curtains to partition their beds. Yes, but what Mr. Frank wants us to know is that for the purpose of NCLEX, this is what one of my friends who just wrote NCLEX told me. Sometimes if we want to relate to or let's say add meaning to what is in our setting here, you'll be getting it wrong. For the purpose of the NCLEX is that once you have pulled the curtains, you still need to what? To speak undertone. Because you cannot say you have provided privacy because you have pulled the curtain and then your voice is heard by another client. That means you are violating privacy. I don't know if I've answered you. Thank you.
Okay.
I think that's it.
All right. So that's it. Okay. We need not to shout. We need not to let others who are not directly involved in client care to hear whatever conversation you are having with the client. All right. If you do that, you violated the client's privacy. Okay. For example, if someone, especially over Ghana here, we do it a lot. You are doing, you are having, or let's say there's a client and you are providing treatment for the client, or you are doing a procedure for the client, and someone will come and peep. Okay. If the client did not consent to that, you violated the client privacy. I hope you get it. So you should be very careful with all these things. But client privacy is very, very important. You need not to do anything to violate. Or if you are in a train or in a bus and you are discussing client issue, are you not violating client privacy? You are.
You are.
Okay. So please, let's take note of these things. All right. I hope we can move on. All right. So there are other things that you must be aware of, that there are cultural practices related to what? Okay. All right. So one of those practices is they do this to just remove illness from their body, okay, or to remove pain from their body. And one, Sister Ifia, please. One way of doing that is what we call moxibustion, okay, moxibustion, or salting, cupping, coining or spooning, acupuncture, acupressure. Okay, these are cultural practices that they do with the purpose of what? Removing illness or pain from the body. Okay, so when you say moxibustion, like combustion, okay, has to do with what? fire, burning. Okay. So what did they do? They put a burning moxa plant. We call it a moxa plant. It's a plant. Okay. They place that moxa plant on the skin. All right. They place that moxa plant on the skin. Let me try to mute someone. Okay. They place that burning moxa plant on the skin with the purpose of what? Removing diseases from the body. All right. So that is maxibuction. It's a plant. The moxa is a plant that they burn. So while burning, it's be on the skin of the patient. All right. So afterwards, those areas can look like a cigarette burns. Okay. So when patient comes and you see cigarettes, something like a cigarette burns on the skin, you have to assess first, because sometimes you might think that, oh, it's a child abuse, especially when the patient is a child. You might think that's a child abuse, but did you assess to make sure that it's not a cultural practice? All right. Another thing is sorting. Sorting, that they emerge the newborn. Okay, the newborn, they submerge the newborn in a salted water. Okay, just to heal. Okay, so they assume that there are odors or sweating. Okay, or there are rashes on the body. So they want to remove the odors, they want to remove the sweating or rashes from the body. They submerge the newborn in salted water. All right. That's with the aim of what? Removing odors or sweating. All right. So that is another type of what? Cultural practice. And then capping. Cap. All right. So they have a cap that is filled with what? Steam. Okay. So it's only steam.
Excuse me, sir. We have not finished with the other slide.
Where is it? Which one, please? Okay.
The previous one.
All right.
The first one.
The first one
before this one.
This
one.
Yes.
Thank you. Yes, thank you.
All right. So sorting, when you put someone in a sort, means that the risk is what? Hypernatremia. All right. So capping, they fill a cap with what? A steam. And they place the rim of the steam cap, okay, on the skin, especially on the back. All right. And then afterwards, it will leave a circular bruise or blemishes on the skin. The same purpose. Want to remove what? Diseases from the skin or from the body. All right. So that rim of the steam cap will leave a circular marking on the patient back. Okay. And there's cooling and also contracting of that heated air. Okay. That heated air will contract the skin and later it cools down. Okay. So that contraction and cooling of the steam cap, okay, will create a suction, all right, which is believed to draw the disease. So whilst the suction is being taking place, it means that the disease of the person is what? Being drawn out. Okay. And because it's filled with steam, there'll be what? Increased blood or supply to that area, and that will heal or pain or promote relaxation. All right. So if patient is having, let's say, poor appetite or fever or congestion, they can use that. You know, steam we use for mostly congestion. Okay. So our patient is having fever or poor appetite, they use that capping to relieve these conditions. Coining comes from the word coin. Okay, so it's a quern. Okay, they use that rounded surface of the quern, okay, to stroke. They initially lubricate the skin, especially the back. They will lubricate. They'll apply lubricants on the back of the patient. All right, and they use that heated quern, okay, to stroke the back of the patient, which has not lubricated, and that one is going to also create erythema and what ecchymosis. All right, so it's they have the aim of what removing what illness from the body. Okay, so if patient is having poor nutrition or stress or fatigue or fever, chills, headache, they can use that to what remove those from the skin. Are you getting it? Any question? Any question?
Sir, I still need the first slide. I have a few things I need to.
This one?
Yes, this one. Yes, this one, please. One minute on it.
Okay. All right, so.
Okay, the next one, please. The next one, please. Okay.
So that is, these are some of the cultural practices that they do. So whenever the patient comes, we have to what? Assess first to know if it's a cultural practice of that person, okay? All right, so please always take note of that. All right.
The next one, please.
Okay, so that is capping. All right, that's capping. So cap is a steam field, okay? And that they use that one to just remove disease, okay? They will just place the rim of the steam cap on the surface of the patient back to remove those illnesses. Okay. All right. Assistant, please can we move on? Okay.
One last sentence. Just this last sentence.
Just what?
Just this last sentence, please.
The next slide.
No, where we are, just stay on this one for one more second.
This one?
Yes. Thank you.
Okay. All right, so that's with the coining. All right. Okay, I hope we can move on.
Yes, thank you.
The last thing that we are talking about is what? Acupuncture and acupressure. It has the same, almost similar method, okay? Acupuncture is what? They insert a thin needle, okay, along what? A desired area of the body, where they think that area, okay, they usually call it what? The meridian, or that pathway. Okay, they want to block that pathway. Okay, so whenever they are inserting that small needle on the back of the patient, they think that they are blocking the pathway, which is causing the pain or which is causing the illness. I hope you get it. That's acupuncture. So puncture is inserting the needle, okay, on the body. All right, with the aim of what? Blocking the pathway that leads to the illness or the pain. All right. Acupressure is applying pressure along that same pathway. Okay. But this one, the acupressure uses what? Pressure. Whilst acupuncture uses what? Small needle. You get it? But it has the same purpose. All right. So, sorry, they want to balance the flow of what? Energy through this pathway, and thereby eventually relieving what? Pain and nausea and vomiting, or hot flashes and fatigue. All right. So these are some of the cultural practices that are believed to be done at the hospital. Okay, so as nurses, we also have to deliver a culturally competent care to our client, all right? And in order to do so, we have to always review their cultural practices. We have to review them. Because you might think that, please, can you mute for us small, please? You might think that the patient is is being abused. Okay, so always review their cultural practices, all right, upon admission. Whenever you admit them, you have to review those cultural practices. That's the best time to review their cultural practices. That's whenever you admit them. Okay, and throughout the shifts, because we have to always review if they have any cultural practices, that if they perform any cultural practices. You shouldn't assume that because they are from this culture, that is their usual practice. No. Okay, sorry if anyone is a Jehovah's Witness here, I want to use them for example, if, let's say, a Jehovah's Witness may come and tell you that he doesn't want to receive blood. Does it mean that every Jehovah's Witness who comes to you, do you think that they have the same purpose of not receiving blood? No, at least one. Okay, one person may opt forward for that. All right, so always don't assume, don't make an assumption, a general assumption. Okay, treat the person individually. Treat every client individually. All right. And you have to also explore their lesion. If they have any lesions on the body, you have to explore that without judging, because that is their culture. Okay, so whatever's finding that you have, you make what you document them. Okay, you document them. Okay, and also make sure that you understand their culture. Okay, and then we have to also provide individualized care. That's as I said, individualized care. You shouldn't make a general assumption. Individualized care for every client that comes to you. Okay, so we should stop the stereotyping. All right. So what other things can we do? We need to educate and re-educate the staff. So every time you have to re-educate the staff, every shift. Our aim is what? To keep them current. Okay, so education is crucial. If you don't educate, someone might not know. Okay, so education is crucial. And self-awareness. You have to be aware of your own cultural background. You have to be aware of your own biases. Okay, and then tendency to stereotype. As I said, you should avoid all those things. You should be aware of your own stereotypes. You should be aware of your own biases. That you don't use biases to treat your patient. You accept their culture, understand them. Okay, and you shouldn't impose our cultural belief on them. No, you should no way impose our cultural belief on any client. Okay, and we have non-verbal communication as well, as part of our culture. Okay, some people, they may assume, they may see eye contact as the best way of what, or as the best way to communicate. Okay, that shows they are being what? Respectful. Okay, but in other culture, it's not like that. Okay, so non-verbal communication cues, we have to also be aware of what, okay, like gesturing and physical distance, because you have to be aware of all these things. So gesturing, okay, whatever you are doing with your body, these are non-verbal communication. Okay, physical distance. Some of them, some culture, they have to keep a very close distance. Some you have to stay like a bit far from them. Okay, and there are also communication barriers. Assuming you are there caring for a patient, and the patient doesn't understand the language, don't you think that we can use the family member who understands the language? Can we use that? Can we?
No.
No.
Okay, very good. So we can't in any way, all right, allow a family member who speaks the same language or a friend or even another nurse who speaks the same language to interpret. No, we should never in any way do that. Okay, so far as there's a language barrier or communication barrier, we should use what? The hospital trained professional. The hospital trained professional should be the only person, okay, who should be allowed to what? To interpret. Not even someone who understands the language, not even another nurse who is a family member or even a family member, a close relative to interpret for the patient. So far as there's a language barrier, only use the hospital trained professional to interpret, all right? To prevent what? Giving false information. Because sometimes you being a family member, you know that whatever the client is saying, if you think that, why should the client say that? You might not want to interpret. Okay, you might say something else. So that's why we always want to use a hospital-trained professional to ensure safety and what? Accuracy of information given. All right? And our health beliefs and practice too, we should also be aware of that. Okay. All right, so there are other cases where there are dietary restrictions. Okay, such as they don't want, some people don't want to eat meat. Okay, you have to be aware of all these things. All right, so kosher, they don't want to eat meat. Okay, some people they are vegan. Okay, you have to respect that. All right, and some people also prefer, if the patient is a female, she might prefer a female doctor to attend to him, to attend to her. All right. If he is a male, he might prefer a female doctor or female nurse to attend to him. That's their culture. You have to respect that. But sometimes in our locality here, we might give it to you. I hope you understand what I'm saying. But we have to allow that. Okay, that's their culture. We have to allow that to make sure that they feel comfortable with you. And sometimes end of life, when they are at that period, okay, some family members want to be present. Some family members even want to do the post-mortem care. After the patient has passed out, okay, they want to do the post-mortem care. You have to allow that. Or they want to assist, or they want to be present before you send the body to the morgue. You have to allow that. It's their culture. You have to allow that. Okay. So we sometimes also have to involve the family members. We have to discuss with them. Okay. How much we need to discuss with the clients if they want the family members to be visiting them. So we have to discuss with the client how much involvement they want. Okay. And with whom? Who should be visiting? Some of them, they are with loggerheads with other people. They don't want everyone to come and visit him or her. Okay. So we have to discuss with the client himself or herself who they want to visit and how much involvement they would want. Okay. And sometimes to transfusion, as I said, Jehovah's Witness, they want to receive blood. Okay, you have to accept that. Or some people, they don't want birth control. Which, can you mention some of the people who generally don't want birth control practices? Yes.
Roman Catholics.
Yeah, Catholics.
All right. They don't want that control. You have to allow that. Okay. So, or sometimes to emergency surgery. Okay. Emergency surgery, we have to also allow, if some of them, unless maybe emergency surgery, you don't, the surgeon want to transfuse the blood, but no one is around. The patient is not having any advanced directives. Okay. In that cases, you can go ahead and do the surgery, all right, and even transfuse. Okay. And we have ethics in nursing as well. So when we talk of ethics, we are thinking of what? Our moral behaviors. Our moral behaviors. Okay. Which help us to distinguish between what? Right and wrong. Okay. And these are determined by our values, our beliefs, our cultural experiences, and our social experiences. Okay. And when we say fidelity, mean that you are being faithful to a promise. You've promised the patient, you want to come back in an hour's time. Did you actually come back? Okay. So we have to be faithful to keep our promise. Okay. You have to be faithful to the client. Right. So when you do that, it's termed of fidelity. Okay. That is, you're being loyal, or you are fulfilling your commitment. All right. And veracity means that you are being honest. Okay. Being faithful is different from being honest. Okay. Being honest, telling the truth, okay, means that you are helping to establish a trusting relationship. So whenever you tell the truth to the patient, it helps to establish a trusting relationship between you and the client. All right. So that is fidelity and veracity. Okay. Autonomy. When you say autonomy, it means that the client can make their own decision. Okay. And we must respect the client's rights, whether to consent or to refuse treatment. Okay. After explaining, after the surgeon or the physician has explained everything to them. Okay. So they have that autonomy to make decisions for themselves. Okay. And when you say justice, means that you are being fair, and not ensuring equitable treatment. Okay. And distribution of resources. So when you are being fair, you are treating everyone equally without distinguishing your care. Okay. You're not being biased. You are being fair to your treatment. If there's equipment that you have to share, you are sharing it equally. If there's something that you have to share, if there's something, the care that you have to provide, you are providing it equally. A patient will call you. Sometimes we want to know if the patient is part of culture before we deal with him or her nicely. Okay, we have to be fair with our dealings. Okay, and you have non-maleficence. Okay, mean that you are doing no harm to the client. That's none, no harm. Okay, but beneficence means that you are doing good. You are doing good. Okay, which is in the best interest of the client. Okay, and confidentiality means that we are providing privacy to the client. Okay, so that is ethics in nursing. These are all ethics in nursing. Okay, and our last topic for the day is what? Care and comfort that are given to end-of-life clients. So end-of-life care, what are we supposed to do? During end-of-life period, everything will try to reduce, especially with metabolism. They slow down. Okay, so metabolism slow down or reduced. It's reduced. Okay, body system will try to slow down. All right. When you take the respiration, usually we have regular pattern of what? Respiration. But if patient is about dying, they usually have what? Shallow, irregular respiration. They can't take in deep breath. Okay, because patient is not having that energy because metabolism has what? Reduced. So patient is not having that energy. So respiration becomes what? Shallow. And that the pattern is what? Irregular. Unlike us who have irregular pattern of what? Breathing. It's more like a child. Okay, a newborn. Okay. They don't have what? Regular pattern of what? Respiration, newborn. Okay. So with those who are about dying, they too have irregular, shallow respirations. Okay. So it may be too slow or what? Rapid. Okay. So the respiration can be too slow. Okay. Sometimes 12 within one minute. Okay. Or can be rapid. They are all signs that will tell us that the patient is nearing or ending their life. Okay. And we have another type of respiration called Cheyne-Stokes respiration. That is when we are having what? Alternating periods of what? Apnea and deep respiration. So patient will cease breathing for a period of time and see patient opening the mouth and taking deep breath once. And then he stops breathing. Okay. And as time goes on, you see the patient opening the mouth and taking in deep breath once. That's Cheyne-Stokes respiration. You get it? Patient might have dyspnea and chest tightness. Okay. It means that these things can lead to what? Anxiety and fear. Because when patient is having difficulty breathing, patient is having chest tightness, patient will think that I'm about dying. Okay, so it can lead to anxiety and fear because of dyspnea, difficulty breathing, and chest tightness. Okay, patient thinks that what is happening? I can't breathe. I can't breathe. Okay, that will lead to anxiety and fear. All right, and they also have secretions. You see them having secretions in the mouth. Okay, so a lot of secretions in the mouth. That will lead to what? Noisy respiration. Okay, noisy respiration. We call them what? Death rattle. So patient having noisy respiration because there are a lot of secretions in the mouth. We call it what? Death rattle. Okay, because sometimes they can't swallow. Okay, so secretion in the mouth will result in what? Noisy breathing called what? Death rattle. And sometimes they can also cough. Okay, because of what? Irritations in the respiratory tract. Okay, so they can cough. So cough is also a sign that the patient is ending their life. Are you okay? Okay, what are we supposed to do if you see patients having difficulty breathing, having respiratory issues? What do? We have to elevate the head of the bed because patient is having dyspnea. Okay, if patient is having a lot of secretions, you can place the patient in a sideline position. Okay, to help drain the secretion and prevent what? Aspiration. Okay, sometimes if they need fan or air conditioner, you can provide that one. Okay, or if they are conscious and they are able to breathe well and they are not able to breathe well, then you can assist them to have what? Pursed lips breathing. Okay, so we'll assume form a purse. The lip of the patient will form like a purse. Breathe in, take in deep breathing through the nostrils. Okay, and bring it out through a pursed lip, slowly through the mouth. Okay, that is pursed lip breathing. If they're having difficulty breathing and they are conscious. All right, so we can't do this to unconscious patient or someone who's like dying and then don't know his whereabouts. Okay, if patient, because of secretions, there are a lot of secretions, you can give what? Anticholinergics. Examples are anticholinergics.
Atropine.
All right, so yes, you can give anticholinergics to reduce the patient's secretions. Okay, antitussives, you can also give that. Okay, or expectorants or mucolytics for coughs. Okay, so we can give these medications as well. If patient is coughing, we want to give mucolytics or expectorant or antitussives, we can give. Okay, what's the problem with the GI? They usually have constipation because they are immobile. They can be lying there for a long period of time, which can lead to what? Constipation. Okay, opioids too can lead to constipation. We know one major side effect of what? Opioids. Okay, like morphine is what? Constipation. So the patient will constipate if they are taking opioids. Okay, or patient, they are not taking in much fluid. Dehydration can also lead to constipation, or if they are not taking fiber or including fiber in their diet, they can also constipate. Okay. Sometimes too, they have diarrhea if they are using laxatives. Okay, if they are using laxatives, they can have what? Diarrhea. And sometimes too, they can have a large bowel movement. That one is it happens just right before death, because they have what? Loss of what? Sphincter control. So you see them passing a lot of what? Feces. Okay, because of that loss, because everything, all the sphincters is losing its what? Contractility. Okay, so that loss of sphincter control can lead to large bowel movement. Okay, and they don't want to also eat. There's decreased appetite. So all these things are signs that the patient is ending their life. All right. What are we supposed to do? Always, you should assess the bowel function. Always assess. Sometimes you, because if patient is constipated, okay, patient might show signs of what? Restlessness, agitation, or confusion. So if patient is confused, if patient is agitated, although they are ending their life, but you see them agitated, confused, restless, it can be a sign that they are having what? Constipation because of immobility, prolonged immobility, or prolonged bed rest, or patient is not taking in fluid, or patient has lost his appetite, or patient is not taking much fiber foods. Okay, so we have to also note that, which may indicate what? Constipation, if patient is having restlessness, agitation, confusion. We can also use stool softener, okay, if the patient is having constipation, or laxative. But mind you, laxative will also cause of diarrhea. Okay, you can give patient enema, all right, or anti-diarrheal for diarrhea. Okay, if patient can exercise, we can encourage physical activity so far as the patient can tolerate. Okay, and because they can't feed, they have lost appetite, what do? We serve them their favorite foods. Their favorite foods. You have to what? Serve those foods to them. At least they would eat something small. and small at a time, small portion at a time. All right. Sometimes they have dysphagia. What is dysphagia, please? What is dysphagia?
Difficulty swallowing.
Okay. And
Difficulty swallowing.
all right, thank you. And that will lead to drooling. Okay. And sometimes because they have difficulty swallowing, it can lead to aspiration. All right. And because they can't swallow, malnutrition, if they aspirate, pneumonia will come. Okay. They can't swallow, it will lead to dehydration. All right. And there's decreased gag reflex. Okay. Which sometimes is caused by what? The weakness. Okay. Neurological disease can cause that. Okay. Or patient is having dementia or Parkinson's disease or stroke or cancer can cause what? Weakness, which will eventually lead to what? Decreased gag reflex. Okay. So there's a decreased gag reflex in patients who are about dying. Okay. What are we supposed to do? If patient can't speak, we can involve, or if patient having difficulty swallowing, we can involve the speech pathologist, okay, to do swallow studies. Okay. And as I said, small feeds at a time. Okay. And we also assess whilst they are eating. We assess for what? Whether they are swallowing, they're able to swallow, whether there's aspiration. Okay, we have to assess all these things. Okay. And if we want to give medication because they can't swallow, we have to give alternative routes for medication administration. All right. So if it's not always that we have to give oral, okay, we can give IV medications if they can't swallow. Okay. So always read the case notes given, okay, or read the preamble. If the patient can't swallow, please don't give oral medications. All right. We also need to elevate the head end just before and during and after eating. Okay. So whilst feeding, you have to elevate the head end of the bed, and they have to remain in that position at least for 30 minutes afterwards. Okay. And because patients, sometimes the family members may be taking care of their patients at home, you have to educate them about risk of what? Aspiration. All right. So that is that. Any questions so far? I think integumentary delirium, postmortem. So we are ending with postmortem. Okay. Any question on that? So next, tomorrow, God willing, we will be able to finish with this and move on to cardiovascular. Any question, please? Are you okay with that? Okay. I think we are much okay with whatever you've learned today. Please, all that you've learned today, please take note of them. Okay. It's very important. Tomorrow, God willing, I will try and see if I will get questions on what you've learned so far. All right. Sorry for today's interruptions, and we couldn't get the link on time. We are sorry for that. Tomorrow, God willing, we'll start as early as possible. All right. Without any further questions or submission, I would like to suggest that we bring our discussion to a close. Are you okay?
Yes, sir.
Thank you
sir.
very
Yes,
much.
sir. Thank you very much.
All right. You're welcome.
Thank you very much.
You're welcome.
Lest I forget, I want to
Uh-huh.
get some clarifications from you.
All right.
Please, the meeting is it Wednesdays and Fridays or Fridays and Saturdays?
Our meetings
I want,
with master
yes,
class, our meetings are
yes.
on Fridays and Saturdays at 4 to 6 p.m.
Oh, okay.
That's with master class.
All right. Thank you very much.
Yeah. So today and tomorrow, every week.
Oh, okay.
Okay. All right. Thank you all. May God be with you. Have a very lovely day.
Me too. Thanks a
Thank
lot.
you, sir.
You're welcome.
Thank you.
Bye.